Perimenopause is the time before menopause begins, of course. And it's interesting, a lot of people don't realize that it's about a 10-year period of time. The average age of menopause is 52. So most women go into perimenopause in the early 40s. And during that time, their hormones are they're not quite as synchronized as they have been in the previous 20, 30 years. So they'll have times where they miss periods, their periods can get closer together, further apart, their bleeding gets heavier, it can get lighter. But it is about a 10-year period of time. During the perimenopause is when a lot of women have crazy bleeding. And I must say I'm somewhat of the feeling of once you're done having kids, who wants to have bleeding anyway? But with the crazy bleeding, that brings a lot of women to our office to please do something for me, fix this crazy bleeding. So that's where the ablations come in, and where we'll end up doing a lot of ablations, and they tend to be done in the perimenopause time. And the ablation is where we just burn the lining of the uterus. It's an office procedure, and it just gets rid of the periods, gets rid of the cramping. During perimenopause, lots of times women will notice that their hormones are not up to par, and they have a lot more, they're more symptomatic and are having more trouble with hot flashes and other issues like decreased libido, problems like that. And natural hormones tend to work very well. We tend to use just a small dose because they still are producing a good bit of their own, but it does help with the perimenopause symptoms. As far as hormone replacement goes with menopausal women, I think this is where it's a huge time for a great dialogue with myself and with the patient, because everybody comes to this with a different background, different family history. For the woman who has a very strong family history of breast cancer, a hormone replacement probably isn't for her. For the woman who has no family history of breast cancer, has a very strong history of osteoporosis, and is miserable from hot flashes, hormone replacement probably is great for her. So it's just a great time for dialogue. For those who are very symptomatic, including me with a lack of estrogen, I'm of the feeling, take my estrogen away, you can just shoot me. So I would, whatever the risk is, that's worth it to me to continue on my estrogen. But it's such a personal decision for every patient, and everybody's so different in how they react to it. So it's just a great time for dialogue and to figure out what's best for that particular patient. One of the big problems in menopause that we see is the incontinence issue. And that's one of the big times that people will come and say, please help me fix it. And a lot of surgery is done during that time. Another thing that we see a lot during menopause is prolapse, or where the uterus or the bladder is falling down. And there are different non-surgical remedies that we can do, as well as surgical remedies. So it's another time where you have to figure out what the patient wants, what is best for her and her situation. They're afraid of menopause and what that's going to mean for them in their life. And there's so much that's out there that's available. It's just always fun to reassure them and tell them that, there are things they can do. There's so much out there. There are new advances every day and ways of repairing uteruses that have fallen down, bladders that have fallen. So it's just an ever-changing world, and there's a lot that's available.